Hey all, I thought I'd try a podcast of the chest x-ray that I posted a day or two ago. It was the 25-year-old male with complaints of shortness of breath for 3 days. And it turned out he had a pneumothorax, and I just wanted to go over it in real time, so to speak, and see if that helps any. So when you're reading a chest x-ray, you need to read it systematically every time on every film. And the method I use is the A, B, C, D, E method. And A stands for airways. And so we go to our airway, and here it is here, of course, coming down. And it looks like the carina is right about there. So you can see this airway may be starting to shift to the patient's right a bit. Maybe not. Looks like it might be shifted a little bit, so that's a little concerning. B stands for bones, and I generally start with the clavicles. And you can see the clavicles here, and it looks okay. And on this side is fine. And then I move to the ribs, and I'm not going to go over every rib. I went over them earlier, and I know there's no fractures. You can see the big first rib back here. That's your first rib. Second rib, third, fourth, fifth, sixth, seventh, eighth, ninth, and 10th. You see the 10th goes down into the diaphragm, and that's how it's supposed to be with a good film. Then we look at thoracic vertebrae, and what we can see, excuse me, looks okay. Looks like I don't see any compressions. It can be difficult to tell a fracture on a standard film without getting the thoracic view, but we can see here's where the second rib meets it. So this is second, third, fourth, fifth, sixth thoracic vertebrae. Looks like the carina is right about T6. And so that satisfies our B for bones. C is your cardiac silhouette, and you can see it comes right here. And it looks pretty normal. That's your aortic arch there. This is your pulmonary window. And it looks normal. There's nothing obscuring any parts of the heart, which would be called a silhouette sign. Could be indicative of pneumonias, consolidations, etc. Although it looks like even the heart may be shifted, or maybe just starting to shift over a little bit. It's very, very early, if it is at all. So that covers your C. D is for diaphragms. Here's your right diaphragm sitting on top of your liver. Then you go over to your left diaphragm, and it's like, well, this looks kind of funny, looks different. The right is supposed to be a little higher than the left, which it is, but this is just a little bit odd. So you look, and this here is the stomach, and this is actually your diaphragm, and it's pushed down or depressed on inspiration. So that's kind of a flag. It's like, what the heck's going on here? So that's your D's, and you can see your costophrenic angle is a little odd too. And there's might be a little straight line right there, which is, if that's a case, could represent fluid. Let me just get rid of that with my eraser. But that's pretty faint, so I'm not sure if I would actually go as far to call that fluid or not, but just to be aware of it. So that's D. E is everything else, and the important part of your lung fields. And I'll start with the right, and I go down my lung fields. I can see that the hilar area is kind of congested, and also on this side as well. I look at my pulmonary vasculature, and it goes all the way out to the edge. So I can see lines and vessels and everything all the way out there, so I know that the right side looks okay. And I go to the left side, and right off the bat, it looks a little different. Let me get rid of these so we can see better. You can see pulmonary markings, vascular markings up in here, You'd really be able to see it if you could magnify it like you can at the hospital. But here you don't really see any pulmonary vascular markings. And same thing with here. Look at the difference between all the markings you see here, and you don't really see anything here. And you go down, and you're still not really seeing much in the way of markings. Nothing, 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 and really nothing down here. And this line here catches your eye. So right here is a line, and that's actually your pleura. And you can see it coming straight down here. And we lose it in that rib, but I'm sure it probably goes like this. And you can also see a line up here, and then it gets caught behind those ribs, but I'm sure it probably comes like this as well. And probably goes up like that. So we found our pneumothorax, and it's a fairly good size. All this is pneumothorax, goes all the way down. And remember, this is on inspiration. So if we were having trouble seeing the pneumothorax, we could get an expiratory view, and I have an expiratory view for this patient, which I'll pop up here in just a second. And it really tends to show the pneumothorax really well. You can also reverse the lighting, and they'll tend to stand out more. And of course, treatment for this guy apparently is a spontaneous pneumo, and a spontaneous pneumo of less than 20%, you can usually treat conservatively and keep them in the ER or admit them for observation for 6 hours or so, put them on oxygen, 100% non-rebreather. And the oxygen really speeds up the resolution of the pneumothorax from many hours to just a few hours. And then you can retake the film in 6 hours or so and check out the improvement and probably send him home. Okay, so here's the expiratory film on the same patient. And you see a huge difference. You can see I've already marked the lung. This is the pleural. Oops, let me get the right pen here. This is the pleural line that I have marked. And you can see it on the film that I've posted already with without any markings. Is really obvious. So that's a hell of a pneumothorax right there. And this particular case is obviously more than 20%, so I'd put a chest tube in him and admit him. But of note, look at this diaphragm. So the right one is fine, and the left one looks normal now. So that diaphragm is on expiration has come back up, and it looks like a normal diaphragm, which is interesting. Now you might see this little dark area here. That might represent some air and what's called a deep sulcus sign. Although normally you get that when the patient is supine and not upright, but that's still, it's a big pneumo, so I wouldn't be surprised if there's some air over there. So anyway, this was my first attempt at creating a podcast. I hope this helps. Reading chest x-rays, I think, is a skill that all CRNAs and MPs should have. And I will hopefully come out with a few more in the coming days on different subjects. So anyway, enjoy, and I will talk to you guys later.